Now, for some reason, he did not stay with this idea. He abandoned it very quickly, and it was picked up by his disciple Otto Rank, who pursued it kind of secretly and wrote a whole book which is called The Birth Trauma, and had it published and didn't tell anything Freud or most of his colleagues until the book was printed, and handed it to Freud. Freud's biographer, Ernest Jones, describes the situation and says that after Freud read this book, he went into a state of shock that lasted 4 months. And the reason for this was that he believed that Rank might have sort of stolen his historical stage, that in retrospect, Rank's contribution will be seen as more important than his own. After these 4 months, he was able to give a kind of fair statement saying that this is a very important theory, second only to the discovery of psychoanalysis by himself, and that it would be important to study people with difficult delivery, easy delivery, cesarean patients, and see what the psychological correlates are. And then he started getting letters from psychoanalysts, particularly from Berlin, who were warning him that this is a very explosive doctrine, that it's going to split the psychoanalytic movement. And because of political concerns, Freud finally excommunicated Rank, and this theory never really made it into psychoanalysis or into mainstream psychiatry. Something similar later happened also with Carl Gustav Jung, who came up with the idea that there's not just the individual unconscious, but also collective unconscious. He was talking about the mythological dimensions of the psyche, about archetypes and so on. Many of the things that we would now discuss in the context of transpersonal psychology. I'm mentioning this because I want to show that the cartography that we were talking about before, this expanded cartography that came out of the work with non-ordinary state, really is not something that's absolutely new. The elements of it emerged in the history of psychoanalysis, but the people who proposed these theories were seen as renegades and really did not have lasting influence. They're kind of footnotes in psychiatric handbooks, but their work is not considered to be relevant, in spite of the fact that particularly Jung's ideas are now becoming very influential in the lay circles and in kind of paraprofessional circles, but certainly in the context of traditional psychiatry, they still haven't made a mark. If we now look at the problem of anxiety from the observations in non-ordinary states, we'll find out that anxiety is linked to life-threatening situations. In nature, anxiety is a signal that the organism is threatened. Either the survival or the integrity of the organism is threatened, and that's the function of anxiety, to mobilize the animal either to fight or to flight. So what we see when we work with people who have problems with anxieties is that they trace it back to anxiety-provoking situations, very frequently actually physically threatening situations. For example, situations of near drowning, situations of operations and injuries, which still kind of as undigested material in the unconscious. So this is the biographical aspect. Then we find out that there's a tremendous pool of anxiety which is connected to the birth trauma, as Freud very correctly saw, at least for the time when he entertained the idea. So birth really involves an element of death. If nothing else, even the easiest delivery, in a sense, is death of the fetus. It's death of one very specific form of existence as an aquatic creature, and then birth into a whole new form of existence as an air-breathing organism. But usually the passage is quite difficult, and in the extremes can be really life-threatening for the child and the mother. So there are different degrees of vital threat that are involved in birth. And people who have anxiety problems usually trace them back beyond the biographical sources to the trauma of birth. And they can actually free themselves from large amounts of anxiety by bringing the birth trauma fully into consciousness and expressing the emotions and the physical energies which are pent up in connection with that trauma. So this is anxiety in general. We talk about free-floating anxiety. For many patients, the anxiety is actually linked to specific objects, and then we talk about phobias or pathological fears. So a classical phobia, for example, would be claustrophobia that many people suffer from, which means they would come to a situation where there's some kind of narrow, crowded space, like the typical situations would be an elevator, a subway, or a small room that doesn't have any windows and has a lot of people in it. And they suddenly start feeling trapped and threatened, and they might start having breathing difficulties, and they have to leave that situation. They have to run out. And when we work with these people using the holotropic method or the psychedelic method, we'll find out that they would discover something in their childhood that links to it, which would be like a situation of being choked by an older brother under a pillow, being locked into a closet or into a cellar repeatedly by the parents, being bound, or being subjected to some kind of forceful medical interventions. Like I've worked with quite a few people in Europe who had the traumatic experience of tonsillectomy, where they were actually, as children, they were bound to the chair, and this was done in local anesthesia. And they were choking on the blood and so on that was flowing down their throat. So we can find these kinds of biographical components, but then as the process goes deeper, we'll find that claustrophobia is linked to the onset of the birth process when the uterus starts kind of closing in. They have literally the feeling that everything is kind of closing in, that they're getting into a kind of a no-exit situation where they are trapped and cannot breathe. And then there could be additional, deeper sources of a transpersonal nature, for example, past life situations that would involve some kind of stay in a dungeon, a torture chamber of the Inquisition, or some other situations where they were trapped and victimized and helpless. Another very common phobia is agoraphobia, which seems to be the opposite. These people are afraid of moving out of a confined place like a house into a place where there are no confines, like a large square or a broad street, for example. But when we actually work with people who are agoraphobic, we find out they're also claustrophobic, but they are more afraid of the transition out of a closed place than they are of the closed place itself. Now, this kind of problem in experiential work would be traced actually to the last stage of birth, which we talked about the matrices, so it would be the transition from the third matrix to the fourth matrix, when the person is just totally compressed and confined, and suddenly there is a transition to a state where there are no boundaries, and psychologically that transition feels like facing annihilation. So when we work with people who get to that stage, we actually give them a lot of encouragement, because they are just one step from a major liberation, but their inner experiences, they're facing annihilation. And psychologically, actually, they are facing the experience of the ego death before the rebirth. Another very closely related phobia is thanatophobia. Thanatos means death in Greek, and phobos means fear. So it's a pathological fear of death. These are people who could be young, absolutely healthy, and they would be experiencing fear of death. They have a sense that they have some kind of condition that's going to kill them. They have the feeling that they cannot breathe, that they're going to choke to death, or they have the feeling of pressure in their head and they feel they're going to have a stroke, or they start having palpitations and they're afraid they're going to have a heart attack. So they usually go to a physician, they have a full examination, and the examination doesn't bring anything that would explain their problem, but they of course feel the symptoms, which are very convincing. So they usually want the second opinion, and if the second opinion is negative, they might want a third opinion. And then sooner or later they might become a kind of menace for the hospitals or for the medical personnel, and to get rid of them, they send them to a psychiatrist. And psychiatrists usually don't treat them much better, because the psychiatrists are physicians, and they look at the medical records and they find out there's absolutely no reason. So they see it as something that these people are imagining, and these patients are usually not taken very seriously.